Harry, not gonna be able to talk to us at this point, guys.
Yes anymore.
Well, Harry's actually doing well. He just said to me, Erica, you know, this makes me really happy. So I think the drugs have kicked in full blast. And Mark is in the middle, Erica, of the procedure. Harry, how you doing? How you feeling?
I'm doing great now.
Okay.
But to be able to, you know, sort of come to at toward the end of the procedure and be able to talk to Mark, to talk to Dr. Pacheco and say, have him say, this all looks great.
Yeah.
Now they're usually not awake, guys.
Clean as a whistle, first of all. So you inserted the endoscope all the way to the end of the colon, and the real test or the real procedure is when you check through the camera on the way out of the colon, right, Mark?
Right. Well, what we're doing now is we're looking at all the little folds here. You can see it on the monitor that as we pull back the scope and we put a little bit of air, and actually we're using carbon dioxide because it gets absorbed very quickly, we could see the intricacies of the colon, see this normal blood vessel pattern. And actually, as I withdraw it this side, you can see there's a little bit of a bluish blush just in the middle. That's actually Harry's liver.
Oh, really?
Yeah, we're what's called a hepatic flexure, which is
Hello, liver.
yeah, not many people get to say hello to the liver. And as I withdraw now, we're coming across the transverse colon. The transverse colon usually has a little bit more of a triangular appearance. You can almost see that as I
look at that.
come back. And actually, it's interesting, there's no bone or cartilage in there. That's all muscle just contracting. And that's what keeps the fluid from coming too quickly out of the body. And the colon's job is really just to remove fluid. It's basically the dryer of the body. It's the sewage system.
And this is just sort of cleansing it so you get a better look. And you also have to look for flat polyps as well. Sometimes polyps protrude out like little warts, I guess, right? But sometimes they're flat.
Katie, what we like to say is they don't always present themselves well.
That's true.
Well, they could be hidden behind folds, or they could be very difficult to see.
I'm a little worried. I told your wife, Andrea, I'd be, you know, if you said anything inappropriate, I'd make sure to...
Yeah, she was afraid I was going to tell too much of the truth.
I want to show you an interesting technology. It's called narrowband imaging, or NBI. And what it is basically a blue light that enhances the vascular pattern.
Wow.
And you see if there was, you could almost see each of those little dots are actually the glands in the colon. And you could see the blood vessels. If there was a very flat polyp or difficult to see polyp, we have
You
a real
really
way
see it.
of
See how
seeing it.
vascular the system
Now, that thing we
is?
just passed, that's not a polyp.
No, that's just a little residue. The colon will always have a little mucus or residue in it, but you can see how clean the prep works in terms of making sure that we can see all the lining.
About a year ago, there was some controversy that some doctors were missing polyps or flat polyps. It really came down to the fact that they were doing the procedure too quickly. Is that right, Mark?
That's right. You know, there are certain quality indicators. One of them is the
procedures at state clinics.
from the beginning of the
They have
colon
them all
to
over
the end. And the minimum amount of time should be 6 minutes. We strive here, we look at the clocks to be at least 8 minutes. And the longer you take looking around these folds, the better you're able to see these little small polyps or flat lesions. You can see how, if you're not careful looking around these different folds, that things could hide. So you have to push forward, and you look around these folds here, and then you pull back. And
When you're getting a colonoscopy, you should ask your doctor, how experienced are you and how long do you take to do the procedure, right, Mark?
Exactly.
Make sure you get somebody who really knows what he or she is
the
doing.
other quality indicators, by the way, is how many times you actually find adenomas. And the baseline standard is 50,
For cancerous polyps?
which are the precancerous
Right.
polyps, the polyps that you really want to find and remove. And the baseline is about 15% to 25%, 15% for women and 25% for men. So they're out there. We just have to make sure we take our time and do a quality exam. Good prep, slow withdrawal, and of course making sure that patient safety and comfort is always present.
And colonoscopy should be done every 10 years. You can do a flexible sigmoidoscopy, but that only really views half the colon, right? It's
That's
sort of like
exactly
getting a
right.
mammogram on one breast.
Not many people do flexible sigmoidoscopies anymore. If you're already in the colon, you may as well look at the whole colon. There's certain groups, like African Americans, that tend to have more polyps on the right side of the colon. So, you know, it's the best way to look. It's really very straightforward.
And how many feet is this?
The colon's
Remember from biology class? From high school, what is it? Is it 12 or 18?
It's 4 to 6 feet is the colon, but
Right.
the small intestine can be 20 feet.
Okay.
And you have apparently a very long colon.
Yeah. Yes.
And by the way, I just want to point out I'm wearing my splash shield because I was told I was going to be in the splash zone and I could have gone all day without doing that, Mark.
Sorry about
But
that,
thank
Katie.
you. Anyway, Erica, we'll come back to you when Harry's done and Mark is finished with the procedure and give you the final prognosis about how it went.
All right, sounds good. We'll check in with you then, but good to hear Harry say that he heard that everything looks good, and good to hear the doctor say that.
Well, that's pretty good. They give you a good understanding of what goes on with those.
Are most procedures like that? Are they away from the
No, they give them a Versed, a little spot of Versed, and a little spot of Demerol.
They keep you away from the reflex though.
I don't know. I've only had them where they put.
They do. They said they
give
put you to sleep, but he
Versed
kept
and
them
a little
awake.
Demerol, and they go to sleep. And you're there monitoring them as the nurse. You're watching the vital signs. You're taking the vitals every 5 minutes as the procedure's ongoing. You're monitoring the respiratory rate. You have the pulse oximeter on. You have them on O2 nasal cannula. If they're too unstable, the GI doctor will do the scope up in the unit at the bedside. So I've done many of those, assist the GI doctor with those MICU patients. And they might, be on ventilators and they scope them while they're, But yeah, that's unusual to be away. See, people don't, this is TV. He makes $1 million or $2 million, and yeah.
Actually, the question is, I tried to ask it before I went to sleep, but they didn't answer it. So, why do they put you on your side so that you can run the scope down?
It's okay. Safety issues, like what could happen, guys? Could happen. But fortunately, with the scope, they can. If you do start having emesis, they'll be able to suck it out because that scope has lots of tools tied to it. And see, it has a spray where you can mitt and clean to look at a site better. It has the capability of doing a biopsy. They can go in with a real tiny forceps to pull out. The scope's pretty intense. This is probably about probably at least $100,000 device, because it's got all these different tools. But safety is the biggest reason. They usually have the patient, all the ones I've ever assisted with, they're on their left side.
Yeah.
And even with the colonoscopy, same thing. Safety. So, because you never know, you put them under sedation, you don't know how the body's going to react. So it's always the safe position because we want to not incur any potential aspiration. So that's why. Okay, lab studies. And you guys probably may have seen some of these at the nursing home, maybe not. A lot of times, if the doctors want to send out the lab, they'll actually have these on the nursing unit. And nowadays, years ago, it used to be we could just arbitrarily check for old coke blood, and we'd show it to the doctor, or give him the results when he came in. But nowadays, what they want us to do is the nurse to gather this, put it inside a baggie, and ship it to the lab. Why? When we can obviously read it, but why is that? Would you suppose? It's a chargeable item. That's how they can make some money, see. But years ago, see, we not so into, we just wanted to get the find out, see. So we just have these cards, it wasn't like, years ago, aspirin cost $7. Who knows how much it costs now? Probably about $25 to administer an aspirin, who knows. Keep in mind, guys, when you're testing for occult blood, there's certain things that you should be aware of, patient teaching items that you should tell the patient. I can foresee this as state board items. I really can. Can't you imagine some of these false positive or false negative kinds of things that they could actually put on NCLEX? What would be, select all that apply. See how they could do that to you? And you would have to select which ones would construe potential false negative or false positive. In fact, I would memorize this slide, especially for next week, because there's going to be one question at least one come from this slide. So there you go. Little helpful hint. But I think strongly that this could easily be on NCLEX. Well, because just the concept of blood, you swallow, somebody would swallow their blood and pass through the system. See? That would be, because remember, we start in the mouth, go down. That's big. Pinworms. This could be another NCLEX item. Clearly, in your PEDS section, if you, if the roulette wheel stopped on the focus being pediatrics, I guarantee this would be one of those questions. And what the nurse's interventions or the process to detect the presence of the eggs. Cellophane. It's the anal opening early morning. And then, of course, they would, they would take that, put it down on a, slide, microscopic slide. That would be sent to the lab for analysis, you see. That's the actual depiction of what they might look like under a microscope.
Oh, they both the same. Yeah, looks like this is cardiac.
Things that happen to us, right?
So that's
okay, so what we emphasize
These are the drugs that fix that.
to promote regular patterns is privacy.
well, this written.
Privacy and time. There's a time. There's a routine people have, isn't
Because
it?
it's saying arrhythmia
Can't
and
rush
dysrhythmia are the same thing.
Don't rush the situation.
Cardiac dysrhythmia is the same thing.
There's things that you need to make time for and have privacy
Terms
for.
of surgeon, disturbed heart rate,
Because you
irregular
guys, if you
absence.
guys are comfortable, guess what? Y'all are going to have better outcomes on your tests even, right? See, good results end in good results. Privacy, positioning. Person that is in bed, on bed rest, and they need to have a bowel movement. And they're already scooted down in the bed, because they've been restless. They're already down in the bed. I just love the nurse that comes in. They answer the call light, and then what they do, they slap that bedpan under them, put the head of bed up, and they're already down in the bed, so they're so uncomfortable. Y'all should experiment and try that sometime, see how it makes y'all feel. So if you're gonna, I say to you, put yourself in that bed like the patient is. Pull the patient up in bed first. Get them to the most natural position. Put them on the bedpan, then try to raise the bed to the most natural sitting position that you can achieve. Ideally, if they weren't on bed rest, the best mechanism is take the time and ambulate them to their bathroom and allow them that time and that privacy. Don't hold yourself. That's why I tell you, if you gotta go, go. Go, guys, go. You don't need to wait. Yeah. Very important. Healthy foods, exercise. And then these are some of the important things that you should teach your patient when they need to follow up with their physician. I highlight this, and I'm actually going to say it again. I'll make y'all read it the second time. But if you have a patient, say, that's having issues, and this is not really necessarily tied to a colostomy here, because we're just talking about normal bowel function, but I say this to you because you may have this in your time as you go through your program, have a patient that's might have paralysis and they might have a colostomy. They're not able to move. You want to have the most natural lying position for those individuals because they don't have functionality, right? They have lack of mobility. So you want to position them on their left side when you're doing some sort of irrigation. Well, you know, the KUB would show this dilated intestine, see? That's just an image, but basically on the x-ray, it will show, it'll point out, it'll come out. And it just becomes a vicious cycle if you can't get that expelled. And sometimes it gets so significant, what do they have to do? They literally have to go into exploratory laparotomy and go in there. That's what happens sometimes. It's just that bad. Things that happen. You guys might have the opportunity to do some fecal impaction removal. Yes, there's always a possibility. Yes. You would want to make sure you had official order for it, of course, because things can go awry with removal, digital removal. You can invoke the vagal response, and then they will break it down and arrest on you. I think I told my clinical group the times that I've had patients that, and I say this, what do you think happened to Elvis Presley, guys? What do you think really happened to him? He was on, he was on a lot of narcotics, wasn't he? Mm-hmm. I bet he was. Wasn't that what happened? Wasn't that what we heard, that he was in the bathroom and on the toilet? He was constipated. He was trying to have a bowel movement. My thought is he probably had a bad heart too. With, you have to imagine he, from the South, foods, greasy foods. He had bad coronary vessel disease, and you have to imagine back, 25 or 30 years ago, we weren't as knowledgeable about things. So here he was on the toilet, and he really arrested, and he was up to like 300 or more pounds, right? I'm thinking he was. And he was on the toilet, and he arrested. He was constipated. He was trying to have a bowel movement. He vagal down and arrested. Cardiac, isn't that what they said happened to him? Do you see how that, and see, you have to imagine he was taking a lot of narcotics. What do narcotics do? It slows the motility of Elvis. That could depict the situation he was in. You see, that's really what could have done it. The vagal response, it's deadly, let me tell you. Administering enemas. You have different types of solutions. Hypotonic, hypertonic, and these are smart. Those are much more, have a higher degree of osmolarity. The hypotonic Fleet's enemas are usually a simple, normal saline or tap water soap suds enema. Y'all maybe heard of that. And they actually have these enema packets that you can get from Central Supply. And it's the brand name, I don't know if it still is, was Pastilles soap. And it would be in this little clear packet, and you would open it up and pour it in, and you would fill up with tap water solutions. And of course, you would hang it, and you guys y'all are all familiar, understand about what an enema bag looks like, right? Mm-hmm. Some of yous, it looks like it's like a bag, okay, let me think, a Ziploc baggie with a tube, mm-hmm. And you could hang it, and the higher you hang it, of course, gravity, right, ensues, right? But here is the state board item, right there. That would be the NCLEX item. They would ask you, what's typically, because why? This is something that you may be given over and over and over. And there's an enema, a medication, yes, you have to get order for that, right? Well, yeah. In the NCLEX world, because there's plenty of time in the NCLEX world for everything. You want to take care of that one patient. Whatever that question stem is, that's all in the whole wide world that you have to take care of when you sit for boards. You must filter out every other conceivable thought in your mind. This is all I'm responsible for. What a perfect world that NCLEX world is. It's not the real world. Managing platelets. a natural byproduct of digestion. We eat these gas-producing foods, cabbage, right? And man, do I love cabbage. Stir-fried cabbage and onions, right? That's good stuff, right? The aftermath. See, and they could actually have that on NCLEX. What would you tell someone, a patient that has exhibited excessive flatus to avoid? What kinds of foods to avoid? And you would have to identify, select all that apply. See how they could do that, right? That's an easy NCLEX question. Always when you're reading your book, you think, now how could they word that as an NCLEX question? Y'all start now, it'll be easy as you progress in the program, and you won't even realize you're doing this. You won't realize you're analyzing your book as you're reading it. You just start now. You're just in your first quarter. Managing bowel incontinence. Well, we have all sorts of products. We have wing pads, we have blue pads, we have these fecal drainage collectors right there. Many a time have I applied one of those to the anal opening in an ICU patient. They're so unstable, you see. They're on ventilators and they're just having watery stool. They have all sorts of devices. Those individuals that need a plan, though, your patient teaching plan, it's very important that you teach them a training program. Training program along with the types of foods and a normal time, a routine, a pattern that helps. Here's caring for patients with bowel diversions. We talked about them previous, but I brought you a few more pictures in. That's a double barrel. These are stomas. Now, that's not a stool, that is a stoma. You see these, that one I can't hardly pick up, I don't see, but now this one is actually stool coming from the stoma. That's a stoma, but that's actually, it's a lower diversion, because why can I say it's lower? Because it's a pretty much formed stool. If it was more in the transverse area, it would be more liquid. As we start dropping into the descending colon area, the stool starts becoming more formed. These are important things to know because on NCLEX they could actually ask those kinds of questions. What would you anticipate the consistency of the stool to be? In which area of the colon, and we're talking about the large intestine, guys, right? That last 3 or 4 feet. And that's what we're talking about. But that's a picture. At stoma, it looks pink to me, doesn't it to you? This one looks pink, what, you know, if you just took away the stool. Yeah. Now I can talk about this and then I can go have full course meal. Doesn't bother me a bit. And that's why that'll be the way it is for you guys. Eventually that's how it'll be. You know, in the beginning, you know, you get a little skittish. But don't worry about that. Things that you want to be concerned about and you would immediately want to tell your physician is stomas that don't look healthy. Those that have a pale color or dusky, that means that they're not getting very good blood supply. A dark necrotic or brown kind of stoma would be of concern. These kinds of things say there's a lack of blood supply and the surgeon's going to have to go in. There's something wrong here. So that's and that's why I spend time, you know, talking about these stomas. Because if they don't look healthy, and that's a healthy one, then we got issues. Or that's a healthy one. See, it's pink. It's sort of reddish, a little irritated actually. The skin, that's why I wanted this picture. See, do you see how the skin looks irritated? You can almost see where they've had that appliance on that one. Y'all see, I didn't mean to cut y'all off. See that? See how it's sort of irritated around that skin is irritated? Because what is skin? It's an organ that sets a person up for infection. You see, we would want to report that, get the appropriate skin ointments. A lot of times we'd have to, the doctor would refer to a wound care specialist to come in and follow the patient, because that can be serious consequences. I told you earlier about the colostomy irrigation. And again, let us say this out loud. With the case of a patient with a colostomy requiring irrigation who is unable to move independently, and all these, see, they're able to move, aren't they? These two examples illustrate that. That's the stoma from the stomach. But those individuals that you'll take care of that maybe they've been paralyzed or they're unresponsive and they have a colostomy, you would want those individuals repositioned on their left side for facilitation purposes. That's why. But in this example, it's a natural position, isn't it? It's really no different than what we would do if we had to administer ourselves an interim, because we want the natural position. Gravity works best. And now we are waiting on pain management. You guys will have pain management on, let's see, what day will that be? Is it Wednesday? Did Miss Algazay, has she covered both her units?
No, she only did.
She just did one, didn't she? So what I want to spend, I want to flip this because I don't want to, I want y'all to focus in on the GI. So
Isn't our test on Wednesday still?
No, it's next week, isn't it?
Next week?
Next week. So what I would like y'all to do for the rest of your time is this. Just over chapter 28, is break into your groups and work on chapter 28's thinking activities. So, not 30s. And after y'all